The next thing we need to explore is the concept of pooling. The first example we'll use in terms of pooling is using health insurance. A key principle in health insurance is cross-subsidization. With cross-subsidization, people pay according to their means but receive benefits according to their needs. This implies that people should join when young and then stay within a medical scheme so that they can get the most benefit over time. A large number of pools, such as medical schemes, makes this difficult as people move, and also the pools are often not big enough to support adequate cross-subsidization. In other words, fewer and bigger pools are better. Let's talk for a moment about intermediaries, and here I will use South Africa as an example. In South Africa, medical schemes are by law not for profit, whereas medical scheme administrators are for profit. Brokers work for commission that they receive either from the scheme and or the administrator. Important here is that a medical scheme is not the same as medical insurance. Medical insurance is focused on determining individual risk, while medical schemes, for example in South Africa, do not determine individual risk. However, you do pay more the more dependents you add to the scheme or the more money that you earn. Important here is the difference between a medical scheme that's not for profit, in other words may not pay out a dividend, and a medical scheme administrator. Medical scheme administrators are listed on the stock exchange, that is the Johannesburg Stock Exchange, as they are for profit and their primary purpose is to make money. The primary purpose of brokers is to add more people to any given scheme, but not to move the same people around to other schemes and thereby just generate more and more money for themselves. Let's look at the second pooling option, mandatory health insurance, otherwise known as universal health coverage. Universal health coverage means that all people and communities can use the promotive, preventive, curative, rehabilitative and palliative health services that they need of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. This is in response to the WHO resolution that states that everyone should have access to healthcare without financial hardship. It becomes complex for countries to decide how to achieve this. Let's now turn our attention to purchasing. This is the last financial term that you need to understand. When we talk about purchasing, what we actually mean is payment of the healthcare provider. And there are three basic options: retrospective payments, contractual or prospective payments, or a combined model, otherwise known as a capitated model. Now with retrospective payments, service is provided first. For example, a patient comes to see a doctor and the doctor provides service. Then the money follows. The risk is obvious here in that in some cases there's no payment that follows. Typical example of a retrospective payment would be a fee-for-service payment, as in my example with visiting a doctor, or a daily rate in the case of a hospital. With contractual or prospective payments, providers are often employed. The advantage is that this contains costs, but patient satisfaction is usually lower. In the third option, the capitated model or the combined model, a practice such as a doctor's practice is paid an amount to provide care per person, irrespective whether the person seeks care or not. So this could be, for example, an annual fee that the doctor or the practice in this case gets for care of that particular patient. What is important here is that the payment does not follow after each consultation. As a result, healthcare providers are incentivized to keep people healthy and not come to the practice too many times in a year. We also then see multidisciplinary practices that might have fewer doctors and nurses and other healthcare workers, because it is cheaper for a practice that a patient sees a nurse twice or 3 times a year and only the doctor once. In this case, the money follows the patient because practices who have more patients on their lists obviously make more money in any given year. Governance in health is an important theme on the development agenda. Leadership and governance in building a health system involves ensuring that strategic policy frameworks exist and are combined with effective oversight, partnerships, regulation, attention to system design and accountability. The need for greater accountability is key, as funding healthcare is very expensive and there's a constant demand to demonstrate results. Accountability involves 1. An understanding, either implicit or explicit, of how services are supplied. 2. Financing, to ensure that the adequate resources are available to deliver essential services. 3. Performance around the actual supply of services. 4. Receipt of relevant information to evaluate or monitor performance. And finally, enforcement, such as imposition of sanctions or the provisions of rewards for good performance. We are almost at the end of this session on health systems. Do you recognize any aspects that we've discussed in your own particular health system? Where do you fit into your health system? We are all consumers of the health system, but are you also perhaps a provider? Think for a moment, what are the advantages or strengths of your health system? And what are the disadvantages or the weakness of your health system? Now, just in case you don't know enough about your health system to be able to answer the previous questions, you can read more about your country and their health system by visiting the WHO page. Search for the word Global Health Observatory. You can then pick the country that you are interested in and read more about the country profile. Thank you for joining me on this session on health systems. I hope you enjoyed it as much as I enjoyed spending the time with you.